like to introduce the next speaker, Dr. Matthew Leonardi. So he's an advanced gynecological surgeon and sonologist in the Department of Obstetrics and Gynecology at Hamilton Health Sciences, an assistant professor at McMaster University, Canada. His special interests are imaging technologies, including transvaginal ultrasound, endometriosis, advanced gynecological surgery, innovation in diagnosis and research. Matthew is on the editorial board of the Journal of Minimally Invasive Gynecology and an associate editor for reproduction and fertility. He is a junior ambassador for the World Endometriosis Society and a next generation member for the International Society of Obstetrics and Gynecology. He is leading in a research program in Canada and contributing to international research studies. So without further ado, let's welcome Matthew for his talk.
Hello, everybody. Thank you, Tracy. That was a very kind introduction, and it's a very kind invitation to be here today at the Chinese University of Hong Kong. I'd also like to extend my gratitude to Prof. T.Y. Young for inviting me today. It's a great honor. When I was watching your talk, Tracy, it was almost like a mirror image of myself talking about this topic, and I was so grateful to hear, you know, where you're at in your thinking about the preoperative investigations for endometriosis and how useful it is. I was also mortified by that clip from The Good Doctor, which not only didn't define endometriosis as correct, which they're not endometrial lesions, they're endometrial-like lesions.
Yeah.
But there's no consent in that whole story, which was crazy for me. They just did what they thought they needed to do without talking to the patient. So, of course, the goal for all of us is to provide the best patient care possible, and we can optimize that by doing the best imaging possible in a non-invasive fashion that then allows for people to understand what's going on with their body and make informed consent for their surgical decisions or medical decisions or pregnancy considerations for all of the pieces that go into the story for somebody with endometriosis. So without further ado, I'll share my screen now and start my presentation. Can you see my slides?
Yep.
Great. Okay. So my talk today is called Useful Techniques in Performing Ultrasound for Endometriosis. Here are my disclosures. And for those of you interested in engaging with me, asking questions or following along on educational platforms, these are various avenues that you can reach out to me. So by email, always happy to discuss. And then I'm on most of the social media platforms where I distribute education, knowledge, papers that are published. Also, I'm on LinkedIn, so please do reach out on any of these platforms. As you might have just gathered, my guiding principle is that patients deserve to know what's going on. They deserve to know what's going on when we're talking about surgical planning, but they also deserve to know long before the surgical planning story happens, because not every single person is going to undergo surgery. They deserve to know why they're experiencing their symptoms. They deserve that validation, which we can now start to provide more in detail with non-invasive imaging, and in particular ultrasound, which is an incredibly strong tool. So I really have entered into this field of both clinical gynecology and imaging, because without that combined nature, I'm relying on radiologists to understand this problem to the same degree that I understand it as a gynecologist. And I'm relying on them taking that huge leap to learning advanced imaging principles to diagnose people. That may be some time from now. And for those of you who are in attendance today in diagnostic imaging, either sonographers or radiologists, it's incredible that you're here, and we're going to take that leap, but it's going to take time. So I started that journey myself. I also never want to be surprised when I'm about to do surgery for somebody, in particular when we have advanced disease involving the bowel, the bladder, the ureters. These cases are incredibly complex, and without preoperative imaging, we are going to have surgical surprises, which is going to lead to many deficiencies in the patient's care and in the healthcare system, as Dr. Law has outlined. More importantly, patients should not wake up from surgery and be surprised by what's happened, which was beautifully depicted in that clip from The Good Doctor. They should not be surprised. We should know as much as possible before surgery. And so for me, when we talk about diagnosing endometriosis and managing endometriosis, they are separate entities, but they are actually unified when we are talking about the imaging piece. Imaging allows us to both diagnose and optimize management. And you see here, you know, ultrasound is the center word, but in some centers, you may replace that with magnetic resonance imaging, MRI, depending on what tools are available to somebody in their center, depending on where the level of expertise is for the team that's doing the diagnostic imaging. When we talk about ultrasound for endometriosis, and I think in some ways this applies to MRI, which is also operator dependent and does require education to know what to do, the general approach right now is to look at the uterus and the ovaries, and that's it. There's not usually much additional commentary on structures outside of those two. There is sometimes characteristics of the pouch of Douglas that are described if there's free fluid within it in the context of query ectopic pregnancy, query hemorrhagic cyst. And if there's very obvious masses like pedunculated fibroids, those are going to be commented on, but otherwise we're not getting any commentary on that pouch of Douglas space from an endometriosis standpoint. So for the basic scan, the potential to diagnose endometriosis is limited other than ovarian endometriomas. We know that ultrasound looking at the ovaries has very high accuracy for endometriomas. So I would suggest, as Dr. Law has done, that we introduce the new ultrasound in town, which is the deep endometriosis ultrasound or the advanced pelvic ultrasound. The nomenclature doesn't matter so much, but what matters is the content of that ultrasound. We must start looking beyond the uterus and the ovaries. We must look directly for deep endometriosis in structures like the bowel, the uterosacral ligaments, which are the most common site for deep endometriosis. We must look in the bladder. We must look at the ureters for evidence of deep endometriosis leading to hydroureter. Posterior vaginal fornix is a common place for deep endometriosis to be. We should look at the rectovaginal septum, though that location in and of itself is actually a very rare location for endometriosis. And then we should start to do some more dynamic aspects of the scan, which include assessment of ovarian mobility. We should be doing the sliding sign, and these demonstrate severe adhesion states. This then allows us to expand our ability to diagnose not only endometriomas, but deep endometriosis and severe adhesions, including pouch of Douglas obliteration, which is a very late stage of this disease. So see you later, basic pelvic ultrasound. As Dr. Law outlined, the International Deep Endometriosis Analysis Group has been leading the charge in proliferating knowledge and skill around the world on this novel ultrasound approach. There are 4 steps. Those were outlined again by Dr. Law, and over the course of the presentation, you'll see I'm going to be talking about the various steps, in particular focused on the more complex ones rather than simply the uterus and the ovaries. For those of you that are keen to access this article, I've put a QR code here in the presentation, which you can pull out your smartphone device, shine your camera at it, and a link should pop up right at the top of your screen. It should take you directly to the article. I'll leave it up for a few more seconds to give you some time. There will be a few more QR codes throughout the presentation. A couple years after the consensus opinion was published, Professor George Condis and I, who's still my current PhD supervisor at the University of Sydney, we published a very practical article, How to Perform an Ultrasound to Diagnose Endometriosis. This is in the AJAM, and this is a free access article. So if you're keen, you can also check that out. We provided an approach to doing the scan, which contains all of the idea components, but is slightly different in the order. And we have suggested a different order to simply optimize the flow of the scan. For example, as you're entering the vagina with the ultrasound probe, you have the ability to start looking at the vagina, the rectovaginal septum, and the retroperitoneal rectum. These three areas can be evaluated literally as the probe is being inserted, which then takes away your need to go back to them later when you're starting to evaluate for deep endometriosis. You can get them out of the way straight at that point. It's also optimizing for the patient because you're not having to go in and out, you're just doing that process once. So we've changed the order about a little bit, and so you can check out this article for that information. Now, I'm going to be providing some very simple tips and tricks with surgical pictures and ultrasound pictures to help guide you all in performing ultrasound for endometriosis. Tip number one is, of course, we have to go back to our basics. We have to understand anatomy, and we have to understand the anatomy that is affected primarily by endometriosis, which is the anatomy of the posterior compartment primarily. So of course we have our uterus here, and we have our ovaries out of sight with beautiful uterovarian ligaments. We have very nice pelvic sidewalls here. This is the area of most activity of endometriosis. So we have our cervix, our torus uterinus, where our uterosacral ligaments combine at the back of the retrocervix. We have our pouch of Douglas or cul-de-sac, which is a potential space. But we do have peritoneum that is part of that pouch of Douglas. This is a very relevant spot. We have our rectum as well. And so this is the surgical depiction, and this is a sagittal view of that same depiction, where we have our cervix coming here out of view. We have our vagina, which is, of course, in the space behind the cervix and extending all the way out of the body. We have peritoneum overlying that vagina. We have our rectovaginal septum, which is not something that you can see at laparoscopy unless you open that space. We have our rectum and the overlying serosa, and then we have this pouch of Douglas space, which currently is filled with fluid. So looking at this on the left again with colors superimposed, this is the peritoneum really that overlies the entire pouch of Douglas. This is a very common site for endometriosis to deposit, usually superficial, but could be deep as well. We have the peritoneum specifically over the back of the vagina, which is that depicted here. We have peritoneum overlying the rectum, which is down here. And this is that very thin space between the vagina and the rectum if you're going into the picture. So if you were to open up here, you would enter that RVS. We must also understand abnormal anatomy. So in this case, we have an ovary on the left that does not contain an endometrioma, but is very clearly abnormal, being pulled underneath the uterus, very morbidly adherent to the pelvic sidewall and the uterosacral ligament and the back of the uterus with superficial endometriosis deposits. We have very clear superficial deposits of endometriosis throughout the peritoneum of the pouch of Douglas, including the peritoneum overlying the vagina, as well as very likely the rectum down here. In this particular case on the right, we have an obliterated rectouterine pouch of Douglas. And this is because the bowel is completely stuck to the back of the uterus, with the uterus being tethered posteriorly. Often on ultrasound, these uteruses are called retroverted. In fact, most of the time they are anteverted and retroflexed, producing what's called the question mark or ear sign. If you don't know from preoperative imaging that there is a deep endometriosis nodule in the rectum here, it may not be abundantly clear at the time of laparoscopy. Of course, you can see very clearly that the uterus and the bowel are stuck together, but there's no evidence of blue-brown hemosiderin tinging at this area. So the only way to know clearly is to see that lesion through the tissue with a technique using ultrasound or MRI that allows us to see through opaque structures that we cannot see through at laparoscopy. Tip number 2 is to never trust an abnormal ovary. Endometriomas are very rarely isolated, and that was depicted very beautifully by Katarina Exakoustos in a JMIG paper a few years ago. If you have an endometrioma on ultrasound, you should have red flags going up to diagnose deep endometriosis. This is a type of endometriosis that generally is the tip of the iceberg for more advanced disease. So if somebody is a general gynecologist without the advanced surgical skill necessary to tackle severe adhesions, bowel endometriosis, I do think that ovarian endometriomas should be a reason for triaging to an advanced laparoscopic surgeon. So do not trust abnormal ovaries because there is usually more advanced disease associated with it. In this clip here, what we're seeing is a unilocular cystic lesion with ground glass low-level echogenicity. This is an endometrioma as per the IOTA-EASY descriptors. What we can also see is that this ovary is completely stuck in this spot just here. This ovary is stuck to the uterus, which is being tethered posteriorly. And we can see here there is a hypoechoic kind of heterogeneous lesion, which is depicting uterosacral deep endometriosis. Of course, the uterosacral ligaments run very close to the ureters. And again, if somebody is operating on this patient without advanced laparoscopic skill, they may not have the capacity to perform a ureterolysis, dissecting that ureter laterally away from the site of disease to then perform proper excision in a way that's safe, not worrisome of damaging the ureter. So in this case, it's not just an endometrioma, there's a lot more to this picture. Tip number 3 is to not trust normal ovaries. We cannot trust any ovaries on ultrasound because, as we showed in the comparison of the basic pelvic ultrasound and the deep pelvic ultrasound, deep endometriosis pelvic ultrasound, if we don't look for deep endometriosis, we're not going to see it. Normal ovaries do not mean that there's not more advanced disease. A few years ago, we published a study that demonstrated in those patients who attend a tertiary center with a scan and then undergo surgery, those who have normal ovaries still have quite a high prevalence of deep endometriosis. About 1 in 4 patients who have normal ovaries had deep endometriosis, primarily in the uterosacral ligaments and bowel. About 1 in 10 had obliteration of the pouch of Douglas, despite the ovaries appearing normal. So normal ovaries should not bring you confidence that this is not going to be advanced disease. Tip number 4 is to try not to confuse the fallopian tubes for ovaries, trying to really understand that they're different structures and evaluating them separately. In many cases of patients with endometriosis that have severe adhesions, there are blocked fallopian tubes leading to fluid-filled fallopian tubes. They can be filled with clear fluid, which would be called a hydrosalpinx. They could be filled with blood, which would be called a hematosalpinx. And the top 2 images we're depicting here a hematosalpinx and a hydrosalpinx in the lower 2. It's important to try and follow the path of these cystic structures to differentiate them from ovaries. Sometimes ovaries can contain quite irregular endometriomas that have potentially incomplete septations and secondary pockets. But following them and understanding, are they tubular, are they serpentiginous, is very important, because these are going to, again, have implications on patients' care with respect to their pain levels, with respect to fertility, and with respect to treatment options. Tip number 5, and Dr. Tracy Law mentioned this as well, is pay attention to low ovaries. If the ovaries are very low in the pelvis behind the uterus, this is potentially suggested that they're stuck there. Most of the time, the ovaries are not stuck in the posterior compartment. But if they are in that posterior compartment, you have to assess whether they are there because they are stuck there. In this clip, what we're showing is the uterus on the left, the ovary in the center, and our uterosacral ligament just here, this white fan-shaped band. When we apply pressure to this ovary, it does not separate at all from the uterosacral ligament or the uterus. It's completely stuck at this junction. If you look very closely, you have this very small cystic area here, which is almost as isoechoic, maybe slightly hypoechoic to the surrounding ovary. This represents a sub-centimeter endometrioma. Without evaluating that location and understanding that it was fixed, there may not have been the same degree of scrutiny to assess whether there was a site of endometriosis that was causing the fixation in that particular location. This is that same patient's surgery. So what we're seeing in the image right now is the uterus, the ovary, and the ureter. We can see as we lift the medial leaf of that broad ligament, the pelvic sidewall, that the ureter is mobilizable laterally, but it is running directly under the site of fixation of the ovary where that endometrioma is. You can see that chocolate cystic fluid starting to rupture there. This is a case that is complex. Even though there's no evidence of endometriosis elsewhere at this point in time, this case, if done by somebody without laparoscopic skills for ureterolysis and ovarian mobilization and overall normalization of anatomy, would generally be an incomplete surgery, would be an abandoned surgery, or potentially in the worst case would result in injury to the ureter. So understanding that complexity preoperatively is essential. Tip number 6 is to perform the sliding sign. And while I do agree that this is a sign that can be incorporated in ultrasound a little bit more easily because it involves the uterus, which we are already always looking at, I do think that we cannot oversimplify its complexity. The sliding sign will be different depending on the uterine orientation between retroverted and anteverted uteruses. It will be challenging in contexts like fibroid uteruses, larger uteruses. So it's not necessarily the most simple thing to do. And in fact, in a learning curve study that we published a couple of years ago in the Journal of Ultrasound in Medicine, we understood that not all trainees can learn how to do the sliding sign in a predefined amount of time, which was 50 ultrasounds supervised. That's not an insignificant number of ultrasounds, and to not be able to master that skill in that duration does demonstrate that there is complexity to this. You have to simultaneously perform the test, the sliding sign, and you have to interpret it, and you have to interpret it in the context of everything that's happening around you. So it is a little bit more complex than we think, but certainly it is one of the things that we can consider integrating into our ultrasound approach sooner than some of the other more complex things. So here we have one way to perform the sliding sign, which is what I call the ballottement technique, whereby the hand holding the ultrasound probe is actually completely stationary. The tip of the probe is sitting in the anterior fornix of the vagina, and the hand not holding the probe is actually just pushing the uterus down, and we are watching the sliding between the posterior uterine serosa and the bowel posteriorly. It's a beautiful sliding sign in this case here. That same technique is used in this patient. Again, stationary right hand holding the probe, left hand ballotment, and we are not seeing mobility in that sliding here. It is fixed, and you can actually see that there is a hypoechoic lesion at the level of the internal cervical os at the retrocervix that is likely depicting endometriosis either within the torus uterinus or uterosacral ligaments, and we are not seeing that sliding there. So this is a negative sliding sign. You will see a clip in a few slides as well, depicting another way that we can evaluate that sliding sign. The next tip, and this I think is my most important tip, is to spend your time evaluating endometriosis in the posterior fornix, the posterior vaginal fornix. So we have our probe. This is the direction that probe needs to head. You need to go direct towards the cervix, and then you need to take a bit of a dive, going backwards and then up again. Why do we want to spend most of our time here? Again, because most disease is in the posterior compartment. Uterosacral ligaments are the most common site for endometriosis. Bowel is the second most common site for deep endometriosis. The posterior vaginal fornix is a common site for it. That sliding can be evaluated in this space as well, which you'll see. So this is an incredibly important place to spend time. In this video, you're seeing the probe entering the vagina, and we're following the rectum. We're following it from the retroperitoneal rectum to the intraperitoneal rectum. My eyes are always on the muscularis layer of the rectum, this dark band here. You can see that there's a posterior aspect as well, but endometriosis does not deposit on the posterior rectal wall. It deposits here anteriorly. So we're following that rectum as high up in the pelvis as we can from the anal verge upward. We're keeping our eyes always on that muscularis. You'll see in these two clips that the uterus is out of view. That's because the probe is in the posterior vaginal fornix. It is essentially lifting the cervix slightly. The cervix and the uterus are out of view, and we're focusing on the space in the posterior fornix. Though not intentional, in this clip, the things that you're also being able to evaluate are the vagina. The probe is always touching the vagina, so you always have the ability to draw your eyes back to the vagina to inspect that area. And you're looking for a relatively thin hypoechoic structure that is on the other side bounded by usually a hyperechoic structure, whether that's the peritoneum overlying the vagina or the uterosacral ligaments. In this case here, again, following that muscularis from top right of screen, as high up as you can, what we're going to notice is it leads us directly to a deep endometriosis nodule of the rectum. You can see that this uterus is being pulled back. It is being pulled back exactly at that site of rectal attachment just here. And then you can also see that the ovary is being pulled down to that site as well. And there is another conglomerate of hypoechoic structures just here in the uterosacral ligament. So often when you see one deep endometriosis nodule in the posterior compartment, there are going to be other nodules in that space as well. Often they are congruent with each other. This can make the evaluation of deep endometriosis the most challenging, I believe, because landmarking where something is important for surgical purposes. Of course, the diagnosis is achieved very easily because you can see how advanced it is. But for planning purposes, you need to say, this is the bowel nodule, this is the uterosacral nodule, this is the vaginal nodule. They measure this, this, this. And that way the surgeon who's going to do the surgery has a plan in place to target those entities. In this case here, we can look at the muscularis layer of the rectum, and we can see that it's uniform. It's thin all the way through. We have some fluid in the pouch of Douglas. But what's important in following this bowel here is it's sort of tented. It's tented towards this area of abnormality. So we have normal vagina right of screen here, but then here, left of screen, we have a posterior vaginal fornix deep endometriosis nodule. And even though the bowel is not directly affected with endometriosis, it is being pulled to that. So this has surgical implications because the surgeon needs to know that the nodule of interest is within millimeters of the bowel. Essentially, what's going to need to happen in this case is the peritoneum overlying this rectovaginal septum needs to be opened, allowing for the descent of that rectum in that space. Once that's descended, it'll be fine, and this lesion can be targeted. We also notice here there are some irregularities over this posterior vaginal fornix deep endometriosis, which are representative of superficial endometriosis, which I'll tell you about in a few slides. In this case here, we have the normal muscularis, and then it leads us to a very large hypoechoic nodule. This is bowel deep endometriosis. What's also happening in this particular clip is that we are applying pressure with the probe. This is another technique to perform the sliding sign. Often this technique is necessary in those with retroverted uteruses. We are not seeing any sliding between this bowel nodule, which is the bowel, and the uterus here. This is another negative sliding sign with deep endometriosis in the rectum. This uterus is being pulled back again in that way. You can have retroflexion with either anteverted uteruses or retroverted uteruses. You just have to understand how much of an angle that fundus is being pulled down towards. All right, so nearing the end here, the uterosacral ligaments are one of my favorite structures because they have been essentially quite poorly evaluated in imaging for a long time, but they hold the secret to diagnosing a lot of endometriosis since they are the most common site of deep endometriosis. What you're seeing on the right is that same picture from the beginning, and what you're seeing on the left is a sonographic depiction of the uterosacral ligament in the presence of some free fluid in the pelvis. The uterosacral ligament is a hyperechoic band that in some cases when fluid is present separates from the back of the vagina. What you're seeing is not the actual separation of the uterosacral ligament, but you're seeing some fluid fill this space between the vagina peritoneum and the uterosacral ligament, depending on the angle of your probe. As you can imagine, based on this picture here, there needs to generally be a degree of rotation to evaluate the uterosacral ligament in its full length. If you were to keep the probe purely sagittal without any oblique rotation, you may capture a segment of it as you lateralize your probe towards the pelvic sidewall, but you're not going to see it in its full length. So you need to turn it slightly. So in this next video here, what we're seeing is firstly, the probe is in the posterior vaginal fornix. The uterus and the cervix are almost out of view. We're seeing the vagina, which the probe is touching. At the beginning of the clip, we're seeing a thin hyperechoic line here. This is the peritoneum overlying the vagina. As my hand is lateralizing, it's actually rotating very slightly, and it depends on which side you're looking at. If you're looking at the patient's left uterosacral ligament, you need to rotate your hand slightly counter or anti-clockwise. If you're looking at the patient's right uterosacral ligament, it is a very slight clockwise rotation. So this is challenging. This is one of the most challenging structures to identify. I have been teaching my fellows for almost a year now, and it's just about now that they're starting to really grasp how to visualize this structure. It's very subtle. It's in a space that we don't spend a lot of time with our probe in general basic pelvic ultrasounds. So it's hard. Why did we do this paper? Because it is hard. We produced this paper, which has pictorials and videos for people who want to better understand how to visualize the uterosacral ligaments. This is the QR code that will take you to that article. We also described various types of deep endometriosis that exist within the uterosacral ligaments that can help us again with surgical planning. As you saw in Dr. Law's videos, the ureters can be affected. In many cases, these are affected by uterosacral ligament deep endometriosis that invades the perimetrium. So understanding the uterosacral ligaments is essential to understanding that type of disease. This is that same still image that you saw, but in clip form. And you can see as the probe moves towards one side, that uterosacral ligament with fluid in the pelvis comes into view. This is without fluid. And here we have a uterosacral ligament deep endometriosis nodule within this hyperechoic band. There's the nodule there. It's also associated with bowel endometriosis and a negative sliding sign. So this is a quite complex pelvic state. I won't spend too long on this slide because it's exquisitely complex, but the point is when you have disease in the posterior compartment, to reiterate, it can often be many different sites. You can have vaginal, uterosacral, bowel, and so spending time there to understand the structures in the normal state will allow you to start to understand them in the abnormal state when there are multiple sites of disease involved, and you need to be very clear about your mapping technique. So we have ovarian endometriomas in both ovaries, we have uterosacral deep endometriosis, we have posterior vaginal deep endometriosis. This uterosacral ligament endometriosis is quite wide in its transverse measurement, extending medially towards that torus uterinus. The left ovary is stuck here, the right ovary is stuck here. It can be very complex. These are the scans that do take longer for sure. The final tip, and this is where I will end, is that fluid is your friend. Fluid can be natural peritoneal free fluid, or it can be iatrogenic fluid that is introduced during things like sonohysterography, hycosi, or the novel technique that we have devised, which is called saline infusion sonopodography. Saline infusion sonopodography is essentially one step beyond the sono and the hycosi, whereby we allow the fluid to collect in the pouch of Douglas, hence the name sonopodography, and we evaluate the structures that are now separated by fluid. The uterosacral ligaments are more easily seen, the bowel is more easily seen, the peritoneum overlying the vagina is more easily seen. So we can see very subtle entities, including now superficial endometriosis. Superficial endometriosis can be demonstrated in various ways. It can be coming off of the peritoneum with hyperechoic foci. You can see hypoechoic small nodules like the last image. So there are various depictions, but it is possible to see it. In this case, we have a hyperechoic projection focus coming off of the peritoneum overlying the back of the vagina. And this is that exact surgical depiction for this patient. So the only way to see some of this very subtle type of endometriosis is with fluid in that space. And so we did a diagnostic accuracy study to look for superficial endometriosis, and the results are very optimistic. When we saw something, it was usually seen at laparoscopy. And so we're looking forward to prospectively evaluating this in a larger study, potentially external validation with other centers, okay? So if anybody is interested, you can reach out. This is the QR code that will take you to that particular paper. And in conclusion, I would just like to again extend my gratitude to Dr. Law and Prof. Liang for the invitation, and all of you for attending today. It's been a great honor. I hope this has been educational, and good luck on the journey to diagnosing endometriosis non-invasively.
Thank you, Professor Leonardi, for the excellent talk. So we now welcome any question, and interactive chatting is also a good way, enlightened way for us to learn. You may type your question in the Q&A box, and then for those who need to obtain the ICME, the QR code will be shown in the following slides. So maybe let me take the privilege to ask the first question for Professor Leonardi. So I know you are seeing really a lot of lesion on ultrasound. It seems that your eyes is even better than what you see during the laparoscopy. Do you think ultrasound could be anyhow more superior than MRI, or superior than when we perform laparoscopy?
It's a great question. I think they're all complementary to each other. They can add value in various ways. I do believe that transvaginal ultrasound, or in those who cannot have a transvaginal ultrasound, transrectal ultrasound should be the first line imaging modality done by somebody with expertise in evaluating for endometriosis. We can see through structures that we cannot see through at laparoscopy. And so not necessarily from a diagnostic standpoint, but from a surgical planning standpoint, the ability to map the lesions, particularly in those who have obliteration of the pouch of Douglas. At laparoscopy, you cannot map those lesions with your eyes. You cannot see through opaque structures. So we have to see those preoperatively. You could see them on MRI as well, but the same caveat applies with MRI, that you need to have somebody who's protocoling that patient correctly. You need to have a radiologist who has a keen eye and a willingness to spend time zooming things up, looking at all of the different structures, and then providing a report that is equally as detailed as the report that's suggested by the IDEA group, listing where all of the structures are and where all of the, are they normal, abnormal? If they're abnormal, are there lesions within them? Are they abnormal because there's adhesions? How many centimeters is each thing? So it's operator dependent regardless. Of course, laparoscopy is necessary still to diagnose some superficial endometriosis. That hasn't changed yet. And there is still a need for histopathology as well, which is, of course, after the laparoscopy as a part of the diagnostic process, because not everything that we see as surgeons is actually endo. So I think we have to get to a point where we have a multimodal diagnostic approach where you can achieve a diagnosis with different ways, we shouldn't simply say laparoscopy is the only way to diagnose endometriosis, because that's not true. And it's also flawed in and of itself.
Yeah. So, any question from the floor?
There
So,
has
sorry,
to be somebody who has a question.
Yeah.
Come on, people. Don't be shy.
Maybe I have one more question for you.
Yeah, of course.
Yeah, if you detect some endometriotic lesion on ultrasound, but then if you can't see those, such as on uterosacral ligaments, that's your expert area, but you cannot see that on laparoscopy. So what is your next step? Like, do you just trust what you see on the laparoscopy, or yeah, what is your next step for that?
Yeah, I've had a couple cases where you see something on scan and then you do surgery and you're like, where is that thing that I saw? It's not so obvious. So you can have subperitoneal endometriosis that's not that visible through the peritoneum. And this might be related to one of the theories around endometriosis being deposited during embryology and being stagnant until puberty, at which point it then starts to develop, the Mullerianosis theory. So, that's possible. And I've had a case or two like that. We do trust the imaging at that point. So we see it on imaging. We believe that this patient has something there. We dissect that area. Would I apply that same concept if I was talking about the bowel? I'm not sure, because the bowel, of course, has so much more significance in dissecting and cutting into than the uterosacral ligaments or subperitoneal nodule. So I think it depends a little bit on context, but I usually trust the scan because I know how accurate it is. Here the questions are coming in.
Yeah. So one question is, do you ever had ultrasound done for your post-operative patients as comparison?
Yeah, thank you, Rachel, for the question. So there has been a study, actually two studies published, one by our group in Sydney and then another group in Italy, looking at ultrasound findings after surgery for endometriosis to try to understand, first of all, what is the state of the pelvis after surgery? Are the adhesions going to completely reaccumulate almost immediately or not? And so there is likely recurrence of obliteration of the pouch, not necessarily because of endo, but probably post-surgical adhesions. I have scanned many of my patients who I've operated on, and sometimes there are other deposits there that were not necessarily appreciated in the first go because of how complex they were in the first scan preoperatively. The thing that I sometimes wonder, though, is what is a normal post-op appearance of the peritoneum or the uterosacral ligament versus a new nodule? Is this actually recurrent or residual disease, or is it simply post-surgical changes? So these studies actually have to start to be done, because otherwise we're never going to know how to evaluate somebody who has already undergone surgery.
So there's one question on how is urethral endometriosis managed? Is the ureter transected? So I think it depends on whether it is an intrinsic or extrinsic urethral endometriosis. Of course, we always need to liaise with urologists for joint management. But then for intrinsic one, I think many of the time we need urethral reimplantation. And for the extrinsic one, then it depends on the severity. And also, like in the case that I illustrated, the pelvic side wall is severely affected by endometriosis. And we think that the chance of like having another like quite dense adhesion over the pelvic side wall is quite high. So we think that, and there's persistent, there's a structure over that site after the excision of the endometriosis. Therefore, we decided to have that part of the ureter transected and then with ureteric reimplantation. So it depends on the severity of the disease and involvement of the ureter. Yeah, and also need to liaise with the urologist to see how they think that ureter is like. So any comment by Matthew.
I totally agree. Yeah, no, that was a great answer.
Mm-hmm. So, Matthew, do you prefer to do ultrasound at luteal phase of a menstrual cycle?
Yeah, it's a good question again, Rachel. You're thinking ahead. So, does endometriosis look different at different times of the menstrual cycle is a good question. We don't know. That's never been studied. It's something that I've been toying with studying for a while. Somebody might beat me to it. But you would think hypothetically that it might be more demonstratable on scan during that second half. The other advantage is, of course, the natural peritoneal fluid that exists in the luteal phase. So that is another idea that needs to be studied. Does the luteal phase fluid state help with superficial endometriosis identification? I think the hypothesis is yes, that it will, but it hasn't been demonstrated yet. And simply because of logistics in booking patients, it's very challenging to try to schedule everybody around their menstrual cycle. And so for now, there's no process for that.
So a few more questions. Also question for Matthew. So how to identify DIE in the ureter rather than posterior part of uterus, since the location is quite high?
Samuel, great question. Mapping the disease site to the anatomical location is one of the hardest things to do. Finding the nodule can be an easier thing because you're seeing this abnormal area, but understanding where is it is challenging. So you have to, again, go back to the basics of understanding normal anatomy and abnormal anatomy. You have to know where your uterosacral ligaments are on ultrasound and what they look like, because if you see a nodule, you have to figure out is it in the uterosacral or is it not? Understanding proximity to the ureters is important. So evaluating the ureters, like Tracy said, is necessary, and evaluating them proximal to where that perceived nodule is very important as well. That can be challenging as disease states can be quite high. So yeah, it's not easy. It takes time to figure out the mapping piece for sure.
Yep. Yeah, totally agree on that. And then next one, how to diagnose adenomyosis with bowel adhesion.
You want me to go, or Tracy, do you want to have a go?
Yeah, I think Matthew also illustrated very well on his lecture that we perform a sliding sign. Yep. Of course, I also find it a bit, so for if the adhesion is involved over the anterior or posterior aspect of the uterus, I think the sliding sign is quite reliable. But then for those bowel adhesion adhere to the fundal area, which is quite high up, then I find it a bit difficult to demonstrate that on the ultrasound. So sometimes I thought it was a quite mobile uterus, but then in the end, indeed, it's all the adhesion over the fundal area, which I find a bit difficult just by relying on the sliding sign. So what do you think, Matthew?
Yeah, you can have the traditional bowel adhesions along the posterior uterine serosa, but you can also have adhesions elsewhere, much higher up onto the fundus and even onto the anterior serosa. So, the bowel adhesions or adhesions in general is a concept that needs to be better evaluated in studies, so that way we can improve our preoperative surgical planning. The concept of adenomyosis is obviously quite a controversial one. It is growing in research and clinical knowledge. There are thoughts that there are different subtypes of adenomyosis, ones that are more external penetrating inwards and ones that are internal penetrating outwards. So there might be a correlation with bowel endometriosis, obliteration of the pouch, and external adenomyosis. So knowing that might help you differentiate features in the uterus that might look like fibroids, but are actually focal adenomyoma. So if you understand where the bowel is, the bowel adhesions, the bowel nodule, it might actually help you with assessment of adenoma.
Yeah. So anomalous question. If the scan is suggestive of DIE, if a patient is relatively asymptomatic, should you offer surgery to prevent worsening of the endometriosis, or go for conservative management?
When you do a lot of scans for other reasons like bleeding or polyps or, you know, ovarian cysts, you pick up deep endo, you pick up ovarian endometriomas that are asymptomatic in people. I scanned a lady on Tuesday who had a 26 centimeter endometrioma. It was, I think, the biggest endometrioma I've ever seen. And she had associated uterosacral nodules, 100% asymptomatic, has had natural pregnancies, no issues at all. She was sent for me to evaluate the nature of the ovarian cysts to make sure that they're not cancer. And so I said, see you later. You don't need any management. You have these huge cysts. They fill her abdomen. She can feel them, but she doesn't have any symptoms. So no management at all for her. So I think, you have to talk with your patient, of course. I wouldn't ever do unnecessary surgery for somebody who's asymptomatic. It needs to be appropriate.
Yeah. So, question from Samuel in concerning of fertility, do you prefer to surgery first or IVF first? So I think this is a very hot topic now. Yeah. And topic that's our of today's seminar. I think it really depends on patients. Yes, it's really individualized management. Also depending on the ovarian reserve for that patient, and whether there's like large endometrioma that may rendering or causing potential complication of doing IVF, such as during the oocyte retrieval. But then on some cases with repeated IVF failure, then I do appreciate there's a role of surgery to if the patient has some embryo or after some failure of IVF, then a definitive surgery to which ablate all the endometriosis may indeed help the patient, but then we need a thorough discussion with patient. And it is really a hot topic. There's really a lot of pros and cons on different aspects.
You could give a whole conference on this particular topic. It's a huge question. ESHRE, the European Society of Human Reproduction and Embryology, actually is doing a series of talks. So if, Samuel, this is something that you're interested in, or others, you could have a look at their program. They're talking about all of the different types of endometriosis and how those impact on fertility and implications. So it's impossible to answer. But the best thing that I think we can do is optimize our pre-op knowledge, or not necessarily pre-op, but non-invasive understanding of the person's pelvis with advanced imaging principles to counsel them as clearly as possible. So that way they can make informed consent on whatever path they want to take. So I really believe that we need to optimize our imaging for all fertility patients, because a lot of them are told they have unexplained infertility when it's probably explainable if you simply started to look harder.
Yeah. So some more question. So could one, this is a good question, could one point be reproducible to be sure that the things you see in scan are really those anatomical structure?
There have been, I'm not exactly, I don't know if I'm interpreting the question correctly, but you have to look at the literature on endometriosis diagnostic accuracy studies to know that the studies have always compared the findings on imaging to surgery. So that the reference standard is what we can see with our eyes. So what we're seeing is generally thought to be real. Same thing with the anatomic structures, although you can't really do a diagnostic accuracy study if you're saying, I'm going to try to find the uterosacral ligaments and then look laparoscopically, because you're not looking for a pathology, you're just looking for a structure. But certainly there have been many inter and intra observer studies that test reproducibility of ultrasound, and the findings are optimistic that what we're seeing is what somebody else is seeing, and what we're seeing is what we see if we looked again later.
Yeah. So is transrectal ultrasound better than transvaginal ultrasound for assessment of DIE or vaginal rectum? Vaginal rectum, rectum, and or uterosacral ligaments.
Probably not for most deep endometriosis. No, but we've just published a systematic review meta-analysis in the ultrasound for obstetrics and gynecology journal, the White Journal, which did demonstrate that transrectal ultrasound has the highest diagnostic performance for rectal deep endometriosis. For the others, I don't think that that's been shown, but I would not do it unless somebody couldn't have a transvaginal ultrasound. It's not going to be so much more accurate that that would be the preferred route of the ultrasound.
And a question from Karen, do you use endometriosis ultrasound to monitor treatment response to medical treatment such as hormonal treatment?
Great question, Karen.
Yeah.
This is another Pandora's box, another very interesting academic question at this point. So the answer is no, I'm not using ultrasound to monitor patients' treatment. The only thing that's really been demonstrated thus far in the literature is that endometriomas might get somewhat smaller on hormonal therapies. And that might have some implications on simplifying a surgical procedure if somebody does have a very large endometrioma and you make it smaller to conserve more ovarian tissue and to have just more visibility at surgery because it's not as big. But no, there hasn't been any research yet to look at how they do with respect to medical treatment. And some people are starting to publish on how the nodules change with time, or do they change with time? And probably they don't. Deep nodules probably don't change very much with time. Sort of once they develop, once they form, once the fibrosis kicks in, they stay quite stagnant.
So I think most of the questions were answered.
That's great.
Yeah.
Thank you, everybody, for the questions.
Yeah, thank you. So I hope that we have enlightened you all with using ultrasound to diagnose, to look into endometriosis and also to diagnose DIE. And yeah, I do learn some more tricks from you, Matthew, today. And I hope, we'll be continue to perform more ultrasound on endometriosis, and we hope that we could see more like you later on. Yeah.
It was great to be here, Tracy. Thank you again. Thank you, everybody.
Thank you. Have a
nice rest of your evening.
Yep. Thank you. Goodbye, everyone.
Bye.